Having EDS doesn't make your pregnancy or your birth story a story of risk. It makes it a story of knowing your body, which, by the way, you probably already do better than most people because living with EDS really requires that of you. Welcome to the Be Well Baby podcast. I'm Dr. Emily Spaeth, founder of Be Well Baby in Portland, Oregon, and the Beyond Birth Blueprint, an online community where we support families through pregnancy, birth, postpartum, and especially life with a baby. This podcast exists because I believe families deserve better than what I am seeing in my work as a physical therapist, lactation consultant, and childbirth educator. Just a quick loving note before we dive in. Everything you hear on this podcast is for educational purposes only. It's not medical advice. Every body and every baby and every season is different, and you deserve support that is personalized to you. Let's get started. I'm so glad you're here. Hey, welcome back to the Be Well Baby podcast. I'm Emily, and I am someone who spends a lot of time thinking about how we can do better for pregnant and postpartum people. Today's episode is one I've wanted to record for a really long time. We are talking about EDS. EDS stands for Ehlers-Danlos syndrome, and specifically what it means for your pregnancy, your birth, and your postpartum experience. Whether you have a diagnosis, you have a suspicion, you've been diagnosed with hypermobility, you've never heard of EDS, or you're a provider who wants to show up better for this population, this one's for you. If you are watching this, you probably already have an EDS diagnosis, or at least a strong suspicion that you have Ehlers-Danlos, or you have hypermobility verging on Ehlers-Danlos, and you're either pregnant, thinking about getting pregnant, or maybe you just found out and you're wondering what this all means for you. I want to start by saying that EDS really doesn't mean that you can't have a wonderful, supported, and empowered pregnancy and birth experience and postpartum experience. But what it does mean is that your body has some specific needs and you deserve a care team that actually understands what those are. So for those of you who don't know me, I'm Dr. Emily Spaeth. I'm a doctor of physical therapy and a lactation consultant and a certified neonatal therapist and a certified trauma-informed therapist. I work with pregnant and postpartum people every day, and my mission is to change the way that people are educated about having a baby. I see firsthand what a huge difference it makes when someone walks into their pregnancy with real information. So that is what we're going to cover today. The latest evidence out there on EDS and pregnancy, birth, and postpartum. So we'll talk about how EDS shows up during pregnancy, what you might need to know about labor and birth, and then also what postpartum might look like. And this includes your pelvic floor and some things to keep in mind about your baby if hypermobility might run in the family. So let's get into it. Since you're here, I'm going to assume that you have at least a working understanding of EDS, but I want to ground us so that we're all talking about the same thing. We're all on the same page. Ehlers-Danlos syndrome is a group of connective tissue disorders that it really affects the way that your body makes and uses collagen. And for anyone who's been on TikTok, you know that everyone wants you to take collagen. So collagen is essentially the scaffolding of your body. It's in your skin, it's in your joints, it's in your blood vessels and your organs, your ligaments, it's in your gut. And when collagen isn't working the way that it's supposed to, all of those structures can be affected. And the most common subtypes is hypermobile EDS, which has like a little h EDS. And that primarily shows up as joint hypermobility, sometimes chronic pain and fatigue. And there are also rarer subtypes like classical EDS, kyphoscoliotic, and vascular EDS, which has its own important pregnancy considerations that we will touch on. So here's the key thing for pregnancy. The hormone relaxin you may have heard of. I talk about it all the time. Your body produces this hormone to make everything kind of open and loosen your joints and ligaments, especially in your pelvis, in preparation for birth. That affects everyone. But if you are already starting with looser connective tissue, you're starting from a different baseline. So that doesn't mean that relaxin is bad. It just means that your body needs more intentional support. So let's talk about what intentional support looks like. Because you're probably thinking, okay, yes, Emily, I know all of these things, but what do I do? What do I need to do about all of this? I know, as a hypermobile person myself, that a lot of patients who ultimately end up with an EDS diagnosis have been dismissed by care providers over and over and over again. One of the most common things that I hear from people with EDS is that their pregnancy pain was written off as just like a normal, you're pregnant. Of course you're uncomfortable. And while some discomfort can be normal, that doesn't mean that we all have to live with it, right? And significant pelvic girdle pain, SI joint instability, hip pain, rib flaring, wrist and hand pain, ankle pain, those are not things that we should push through ever. They are your body asking for support. And if you're watching this thinking, maybe I have EDS, but I'm not sure, it doesn't really matter. If you're in pain, you should be able to find a provider who can get you out of it. So specifically for EDS, pain can show up in the front of your pelvis, deep in your hips and in your low back, or even radiating down your legs. So if that's you, please get a referral to pelvic floor physical therapy. If you are in Oregon or California or any of the other states, there is direct access. So you can just go. You can come see me for pelvic floor and I will help you. But earlier is better. A good physical therapist can help you build stability in your core and your hips without overstretching the joints. One of the hallmarks of EDS is that they're dancers. We're yoga people. We love those things because we're good at it because we can move that way already. And they're not great for our joints. So a good physical therapist will know how to modify your movement without taking it away because we want you to move. You have to move. And we want your daily activities to not have to shift, but we should modify them so that you can get really strong and stay really strong in pregnancy without hurting yourself. So there are also some support tools like SI belts or pregnancy support bands, compression garments. There's a whole company called Jelly Bands. I'll link to it for you so that you have it. But it can really make a huge difference day to day. If you are one of the many people who also has POTS or other dysautonomia, which occurs with hypermobile EDS in a significant number of people, pregnancy can really amplify POTS. So, and if you don't know what POTS is, POTS stands for postural orthostatic tachycardia syndrome. And the reason that this is affected by pregnancy is because of the changes in your blood volume. So essentially you stand up and your heart rate spikes and it can lead to dizziness and fainting and fatigue and things like that. So the increased blood volume, positional changes, and the cardiovascular demands of growing a baby can make things like the dizziness that you experience, your heart racing, and fatigue way more pronounced, especially in the second trimester as your blood volume peaks. And these are the moments where you start to feel lightheaded and you're like, I think I might pass out. And we don't want that to happen. So some things that help are stay really well hydrated and increase your salt intake if your provider approves it. Generally, they're like, yes, please eat more salt. Compression garments can really help with this. Smaller and more frequent meals. Being thoughtful about your position changes. So don't get up super fast. If you're getting up from laying down, take a minute. Especially when you are working with a healthcare provider, if they have you laying down, they're palpating your baby, and then they have you stand right back up, let them know that you have this so that they can factor that into their exam. I want to jump into GI symptoms because EDS often affects your gut motility, and pregnancy can make this worse alone. So together, the nausea, constipation, gastroparesis symptoms, and acid reflux are all so much more common in EDS pregnancies. So work with your provider on managing those, especially because severe nausea and vomiting can affect your nutrition and hydration in ways that totally matter. The other thing is generally, I know I mentioned salt, but if you are taking electrolytes, you're a person who loves taking electrolytes, make sure that you are taking enough because sometimes electrolytes are harder to absorb for those with EDS. If you have classical EDS or a subtype that affects your skin fragility, your skin might be more prone to stretch marks. Also, this is hormonal, so sometimes we're just more prone to stretch marks. You also might be slower to heal after procedures and more sensitive. And this is worth discussing with your care team. If any procedures like an amniocentesis or potential cesarean, if any of that is on the table, talking about your healing is really, really crucial. If you have vascular EDS, this is a conversation I really want you to have directly with a maternal fetal medicine specialist who has experience with connective tissue disorders. And these people exist. So find someone who has this experience. There's no reason for you to settle. Vascular EDS carries specific risks in pregnancy related to arterial and uterine fragility, and you deserve specialized, individualized care. So don't navigate this one without a specialist on your team. And speaking of your team, let's talk about building that team. Because in general, I strongly encourage anyone with EDS to seek out an OB or midwife who has experience with connective tissue disorders specifically. Ideally, alongside a maternal fetal medicine specialist and a pelvic floor PT, ideally a provider who understands dysautonomia, if that's part of your story, that POTS that we were talking about. This is not about your pregnancy being scary. It's about having a team that helps you actually feel supported and never gaslit. And it's never the intention of our providers to do this, you know? However, it happens. And if that's how you feel like there's something going on that's not getting addressed, you deserve better. Let's dive into labor and birth itself. So one of the most important things to know about EDS and labor is that your pain experience might look different. Some people with EDS have enhanced pain sensitivity, meaning you might feel contractions more intensely than average. But come on, pain is always, always, always subjective. Some people find that certain types of regional anesthesia, like epidurals, work differently or require adjustment in bodies with EDS. There are also reports of local anesthetics sometimes being less effective in people with EDS. This can happen in dental settings too. So if you've noticed that in your own body, pay attention. And if you're planning an epidural, share that with your anesthesiologist ahead of time. It does not mean that an epidural won't work, but it means that your team should know about your condition so that they can monitor and adjust as needed. Now, if you are planning an unmedicated birth or a birthing center birth, a home birth, building a really strong toolkit of non-pharmacological pain support, movement, water, counter pressure, positioning, all of the positions, having your partner understand what really works for you, that is going to be helpful for anyone, and especially for those who want some flexibility in their birth. Having a doula who understands EDS or hypermobility can be an incredible support here. I want to dive into positioning in labor because this is where pelvic PT knowledge really pays off. I've also done training with an exercise physiologist to really look at birth and the positions of your legs and your body to know what positions can actually be helpful to open your pelvis, because sometimes you're doing something that's counterproductive to having a baby. I also know that so many positions can feel unstable or counterproductive for hypermobile joints. In general, hands and knees, side lying, and semi-reclined positions tend to feel more supported than a deep squat, for example, for many people with EDS. But your body will tell you so much during this process. And part of what I teach in Beyond Birth is the skill of listening into your body, listening to your intuition, and learning how to trust that piece, because it matters so much and it will matter forever. I just wanted to pop in here and say that if the Be Well Baby podcast has helped you in any way, if our team has helped you in any way, the people who find us because they heard about us from a friend, because they heard about us from a midwife or a doula or their pediatrician or their OB. And we value those connections so much. And we know that the only way for people to find excellent healthcare is for people to talk about it. So if you have a minute, please leave the podcast a review. It will help people find this podcast. If we band together and shout this from the rooftops, then we will be able to change healthcare. Thanks. You're also in such a unique position right now. As a pregnant person, your brain is shifting. The gray matter in your brain is changing and pruning to keep only the things that are the most important. It's making room for this new human, which also acts as this incredible sponge moment where everything that you learn right now is going to be of such value to you. So in the birthing room, avoid staying in one position for too long. And that counts for like a yoga class that you took on Tuesday as well. Anytime someone is asking you to stay static in a pose, deep or not deep, being still is not the goal. So flow in and out of movements if you can, especially if your hips or your pelvis are talking to you. Movement is always your friend. We're always wanting to bring more synovial fluid into the joints, so more lubrication to the joints. And just be mindful of those positions that ask you to hold an extreme range of motion. That's where you can really start to strain your joints. So that we talked a little bit about kind of early labor and what you can do in early labor. But when it comes to pushing, a supported approach tends to work better than the classic hold your breath and push as hard as you can method. I talk a lot about this in the Be Well Baby podcast episode with Dr. Sarah Reardon, where you are being coached to push. And for people with EDS, it actually tends to work better when you are pushing, when it feels like you need to push, breathing as much as you can through the pushes, even if it's a low audible exhale or something where even when you're doing horse lips, so that there is air moving even as you are increasing your intra-abdominal pressure. And vocalizing can kind of trick your brain into reminding you that you're safe. So it might feel silly, but one of the ways that I love to teach people to practice is while you're pooping, because we all poop. So next time you poop, take a deep breath in, let your diaphragm come down, and just breathe out your poop. Don't push at all. Just keep breathing and see what happens. So that's your practice for having a baby. And that will reduce the strain on your pelvic floor overall as well if you poop like that. So really talk to your providers ahead of time. And if you're in a hospital setting and you have nurses that are switching every 12 hours, then really discuss your preference for a slower, more guided second stage of labor rather than coached, take a deep breath, hold your breath, push. And I say this knowing full well that probably more than half of the people listening to this will think, great, I'm going to do this. It's going to be great. And then you get there and you're like, the only way I can figure out how to push this baby out is to hold my breath and bear down. And that is okay too. So really know that there's no right way. But if you can try, at least for most of the pushes, to breathe as you're exhaling and pressing, it can be so powerful. The other thing about this is that practicing pushing with a pelvic floor PT is one of the most powerful things that you can do. So be sure that you are asking your provider about this. And remember that spending a long time pushing isn't necessarily a problem. Sometimes giving the perineum more time to stretch gradually can actually reduce your risk of tearing. And let's dive into that because I know that perineal tearing is something that scares everyone and it's so common. The research on EDS and perineal trauma specifically is totally mixed. Some people with EDS have more elastic tissue that actually tears less, and others have tissue that heals more slowly after a tear or an episiotomy. Know that episiotomies are not considered standard of care. You should not be offered an episiotomy unless it's an emergency. So allowing your body to tear is actually going to heal better. What's consistent for EDS is that healing might take longer. And if you do have a tear or a repair of any kind, your wound healing process deserves extra attention and support in the postpartum period. It's really easy to forget as soon as that baby is born that you also have a body that needs to heal. So let's talk about cesarean birth because a lot of times when you're having an abdominal birth, if it's a planned cesarean or it becomes necessary, there are a few things worth just being aware of as you go into this. Wound healing is slower, right? So follow your care team's instructions about activity restrictions really carefully. This is a case where powering through and doing more and strength training does not serve you. Scar tissue after a cesarean can also really affect your core and pelvic floor function. Adhesions can be very deep. There are 7 layers that they cut through. So abdominal adhesions are not something to scoff at. It's really, there's a lot of research about it, and working with someone who understands how to treat abdominal adhesions is exactly what you want. Also, and this applies to all birthing positions, if you're going to be in a position that requires hip abduction or your legs going out to the side for any extended period of time, please ask your team to be mindful of the range you're being placed in, especially if you have an epidural because you can't feel it. Really protect your hips during any of the procedures that need to happen. I know from firsthand experience that my right hip took about a year to heal after my birth because one of the people holding my leg, who will remain unnamed, was holding it just a little bit too tight, too high up, and pushing on it a little bit. It was, birth is the hardest thing that we ever do in our lives, right? And when you are the support person for a birthing person, it is also really hard, especially if they have an epidural and can't feel. So just be aware of where your legs are and don't be afraid to ask someone to push less or hold your leg there. Whatever it is, don't be afraid to ask. And one more quick note on birth. If anything feels off for you, if you are having unusual pain in your abdomen, if healing seems to be slower than expected, if you're noticing symptoms that feel more significant than typical postpartum recovery, please advocate for yourself and contact your care team. EDS bodies sometimes need a little bit more follow-up, and that's okay. Don't ignore your body. Okay, we're diving in now to the pelvic floor after birth. This is a topic that I am deeply passionate about, so bear with me for a minute. Your pelvic floor is a gorgeous group of muscles, fascia, and connective tissue at the base of your pelvis. It supports your bladder, your bowels, your uterus. It contributes to your sexual function, the way that you made this baby, potentially. And it works with your deep core and diaphragm, the respiratory diaphragm, your breathing muscle, to create stability throughout your entire body. Your pelvic floor is the floor of your entire body. So for someone with EDS, the pelvic floor is already working in a body with less connective tissue integrity. And then you add pregnancy, birth, and the hormonal changes of the postpartum period on top of that. So here's what this means practically. Your pelvic floor needs support after birth, and the kind of support it needs is very specific. More is not more. I see many people with hypermobility who think they need to be doing 100 kegels a day. But If your pelvic floor is already overactive or carrying too much tension and living sort of up high in this little area of tension, you might have been compensating for years for your joint instability, and more Kegels are not the answer. It can actually make things worse. So please, please be seen in pregnancy and in postpartum by a pelvic floor provider, not at 6 weeks when you get clearance and your provider says you're good to go, but as soon as you want to. If you see someone during pregnancy and you connect with them, that can be such a valuable relationship because they will know, they will tell you when it's safe to be assessed, which is typically around 6 to 8 weeks. But your PT would love to look at your scar and tell you how it's healing and tell you if it's not healing. There are so many things that a pelvic floor provider is so good at. And all of the weird questions you have, we want to answer them. So some things that you might notice that are worth addressing. Not panicking about, not panicking, but addressing. If you are having symptoms of pelvic organ prolapse, this is very common. Heaviness or pressure in your pelvis, a bulge coming through your vulvar vestibule, leaking with coughing, sneezing, or activity, pain with intercourse, not having any desire to have intercourse, but maybe thinking about that and being a little bit afraid, pelvic pain that doesn't seem to be resolving, ongoing low back pain, hip or SI joint pain. I mean, honestly, this applies to everybody, right? Not just those with EDS. These are common symptoms, right? But they're all treatable. And they're not just part of having a baby. You do not have to white knuckle through this experience of your life. There are people out there who can totally help. I have to address returning to exercise for my patients with EDS because the research is really clear. This needs a really graduated, intentional approach. The general guidance for postpartum return to running and impact activity is at least 12 weeks. But honestly, for so many people with EDS, taking it way slower and building a strong foundation first is always the smarter path. And maybe also for everyone, everywhere. So starting with breathing and deep core connection, this is frustrating for people who just want to go for a run, asking you to breathe. But remember why we're progressing from that deep core to stability work. And then once that foundation is so solid, it's going to serve you in the long run. You won't get injured as easily. You'll have this strength. And I know that it's hard to hear if exercise is part of your identity. It's hard to feel like you're going backward, but really what you're doing is rebuilding intentionally with a body that can keep up with your life for years. So I always tell my clients, you are resting now so that you're not peeing yourself when you're 70, right? But if you have EDS, it's more dire than that, right? Like this is about chronic pain and the body that you have to live in. And it can be a very, very emotional thing. So I also just want to acknowledge that and let you know that there are so many providers out there who know about this stuff and they're waiting to help you. Okay, so one of the biggest things that I see in my practice is that posture. When you're breastfeeding or chest feeding, the repetitive static positions involved in feeding can be super, super hard on a hypermobile wrist, shoulder, an elbow, neck musculature. So this is one of those things where physical therapists, lactation consultants, occupational therapists are all so good at looking at your positioning and trying to find ways for your body to do this repetitive task without ultimately getting a repetitive stress injury. So things like a nursing pillow and supportive positioning tools, pillows in general. I find sometimes that a boppy doesn't do it, but a breast friend does. Or a breast friend doesn't do it, but we use 6 pillows and it's great. So really trying to reduce the load on your arms and shoulders and your neck. So looking down really increases the load on your neck. And wrist pain is so common. So for Wrist pain is so common, and for those with EDS, it can be way more significant. Using a brace and definitely guidance from a PT or OT can make a huge difference. If your baby ever needs a pacifier, and not all babies do, the one that I would want in your world is the Ninny. It's the only pacifier designed to actually mimic the shape and function of the breast. It looks like this. It's very soft here, like an areola, and then harder, like a nipple. And this shape means that it supports healthy oral development instead of interfering with it. I really love it because babies don't just passively hold it in their mouth like the ones with a bulb on the end. They have to actively suck. It's hard work. It's my workout pacifier. And that matters for feeding, for regulation, and for long-term oral function. It's especially beautiful for breastfed babies who need a little extra soothing without confusion. If you're listening and you're pregnant, postpartum, or buying for someone you love, you can grab a Ninny through the link in the show notes or use the code BeWellBaby for 10% off at checkout. Okay, I want to dive into something you may have thought about, but not even really wanted to think about, and that is your baby. Is your baby at risk for EDS because you have it? So I get this question all the time, and I get these questions about baby development. You know, parents with EDS have a lot of times been dismissed by the medical establishment, and then they are having this baby and they're like, is my baby going to go through their whole life doing this too? I won't have it. So the answer about your baby and genetics is it depends. We just don't know. There are so many subtypes of EDS that have a genetic component. And if you do carry the relevant genes, there's a chance that they could be passed to your child. But for hypermobile EDS, there's no specific gene that's been identified, which makes genetic testing really limited. The condition does run in families, though. So this doesn't mean your baby will definitely have EDS. And even if they do, a lot of kids with hypermobility thrive with appropriate support and awareness. Sometimes what I see is babies with lower muscle tone, which is essentially the muscles that they are born with are just a little floppier than average. And those babies do struggle to reach their milestones. But with support and with the right education, they're able to reach their milestones with a lack of frustration that I see in so many babies who haven't had support from early on. So some things you might watch for is when you lay your baby down, do their arms just kind of flop by their sides and their head turns to the side and they're not really holding their head in the middle? That would indicate to me a little bit lower muscle tone. And if they are having feeding difficulty, a latch that doesn't work or feeding difficulty that doesn't resolve with typical support, if they are not reaching their motor milestones, or if it seems like they have more flexibility in their joints, none of those things are emergencies, but they are worth taking a look at and talking to an expert about. You know, when I work with babies, it is a honor and joy to be able to walk with them through their first year of development and help to educate parents on all of these things that can be really simple, but nobody knows. So I think having somebody in your corner who can explain the reason that it's really important for your baby to reach these milestones, for example, or the best way to help your baby learn to roll, it can just be so valuable. So back to that feeding question and the muscle tone question. If babies have low muscle tone, their oral tone, the tone in their mouth, is probably going to affect their ability to coordinate a suck, swallow, and breathe. So if you are struggling with breastfeeding or chest feeding and your baby seems to be working really, really hard, they're clicking, they're taking in a lot of air, they're tiring really quickly, it's really worth getting assessed by a lactation consultant who is familiar with low oral muscle tone. Also, this is not a reason to stop breastfeeding. I get this question a lot. You'd be surprised. People wonder, oh, my baby seems to have low muscle tone. I think I need to stop breastfeeding. But it's not a reason to stop breastfeeding. It's a reason to get the right support and the right education so that feeding can work for both of you. Before we wrap up, I want to leave you with some data because I am a lifelong learner. I always want to know what the latest evidence says. And I think that it's important that you hear this. There was a survey of perinatal healthcare providers where they were asked to rate their own knowledge of EDS on a scale of 1 to 4. Physical therapists scored the highest, go us, at 2.21. Obstetricians and anesthesiologists came in at 1.81, and midwives scored 1.38. These are the people in the room when you give birth. So when I said earlier, you deserve to have a provider who understands EDS, yeah, you do. And also, you might need to do a little education if you love your provider and you want to stick with them so that they are informed as to your diagnosis and what it means. What else this means is that when you walk into your provider's office, you have more knowledge about your own body than they have about your condition. It's the reality of where the research is right now and what providers have in their toolkit right now. So another thing that data showed was that in people with hypermobile EDS, pelvic girdle pain during pregnancy is nearly 4 times more prevalent than in the general population. And folks with hypermobile EDS are 3 times more likely to need a referral for intervention because of their pelvic pain. Nearly 35% experienced precipitous labor, meaning labor that took off and was completed, baby out, in under 3 hours. Postpartum hemorrhage rates run over 20% for people with EDS. And PTSD following birth is reported in nearly 19% of people with hypermobile EDS. And if you also have POTS, over 60% of people with the EDS POTS combination reported that their dysautonomia symptoms got worse after delivery, not better. This could, there's a little bit of nuance to this research. This could be that the hormone shifts of postpartum are so much, and once you are through that 4th trimester, things will improve. So all of that data can feel a little bit scary, but really what this is meant to do is arm you with information. Because here's the other thing that research said. When people with EDS have informed, prepared care teams and go into their pregnancy and birth and postpartum experience with real knowledge about what their body needs, the outcomes are better. Physical therapy is so effective, and early intervention matters. And you are not asking for too much when you ask your providers to understand your diagnosis. Okay, we covered a lot. I want to bring it back to the most important thing that I'd love for you to walk away with today. Having EDS doesn't make your pregnancy or your birth story a story of risk. It makes it a story of knowing your body, which, by the way, you probably already do better than most people, because living with EDS really requires that of you. It requires discovery. And what it means practically is you are going to be building a team intentionally. Your goal is to get pelvic PT early, ideally in pregnancy, and to work with a PT who's comfortable working with you whenever you are ready postpartum. Advocate for yourself clearly and know that the symptoms that feel hard they are really hard, and they are treatable. So you deserve providers who understand that and who see you, who see the whole picture of you, and will help you prepare, not just react. I think, prevention isn't that sexy, and that is a big problem that I have with my mission in life, because educating people to empower them, to give them advocacy tools, you don't know necessarily what you're going to need. And I am here to tell you that having someone in your corner who knows this stuff is going to be so valuable. And even if you are like one of my very favorite clients and you start with me before you get pregnant and you hang out every single week on the calls and you take every single class that I have taught, there will be something that comes up that shocks you. And if you want to keep learning and have ongoing access to this education and support throughout your pregnancy and through the first year of your baby's life, the Beyond Birth Blueprint is an amazing next step, and I would be honored to support you through this journey. Also, just so you know, this podcast episode is the result of a conversation in the Beyond Birth Blueprint. So when you're there, if something comes up that you didn't learn about or that we haven't gone over, you have an Emily that will make you a podcast episode. It's kind of miraculous. Can't wait to see you there. Take care of yourself, and I'll see you next week. Audio and music production by the amazing Peter Gary, with Lillian Ewert managing all scheduling and operations of Be Well Baby, including this podcast. Thank you both for making this happen. New episodes drop every Wednesday, and I'd love for you to follow us on Instagram at BeWellBabyPDX or visit BeWellBaby.org to book a time to chat with us. And if this episode helped you, please send it to someone who's pregnant, postpartum, or someone in your life who wants to support you better. No one should have to do this alone. Welcome to Be Well Baby. You're in the right place.